Hi, my name is Katie Falloon, and I'm excited to be leading this month's IBD Journal Club. Thank you to Dr. Ali and to the Virtual Education Committee for this opportunity. Today we will be discussing the article by Dr. Vedo and colleagues entitled Vedolizumab or TNF-antagonist use and risk of new or recurrent cancer in patients with inflammatory bowel disease with prior malignancy, a retrospective cohort study, which was accepted for publication in Clinical Gastroenterology and Hepatology last month. Please forgive some of the slides to come marked with journal preproof. The final manuscript has not yet been published. Overall, there is a lack of robust data characterizing the risk of new or recurrent malignancy with initiation of biologic therapy in patients already diagnosed with cancer. Though the available data offers some reassurance, many providers wait at least 2 to 5 years prior to starting biologics. Among the biologics available, there is some thought that Vedolizumab may have the best safety profile given its gut selectivity, but data here remains limited. The primary aim of this study was to characterize the risk of new or recurrent cancer in patients with IBD who received Vedolizumab following an index cancer diagnosis and compare this to the risk in patients who received anti-TNF therapy or no immunosuppression at all. This retrospective cohort study included 463 patients with a confirmed history of malignancy and diagnosis of IBD. On this slide, you'll find an overview of the baseline demographics and disease characteristics of the patients, as well as characteristics of the new or recurrent cancer. The median time to initiation of Vedolizumab was 3.9 years, and to anti-TNF therapy was 1.3 years. I'd like to draw your attention to a few points. First, patients with UC were more likely to receive no immunosuppression. Second, exposure to antimetabolite therapy was similar across biologics and did not influence cancer risk. Third, the incidence rates for new or recurrent malignancy on Vedolizumab, anti-TNF, and no immunosuppression were 2.2, 4.2, and 5.6 per 1,000 person years, respectively, and there was no statistically significant difference amongst them. You can see the new or recurrent cancer-free survival among the groups since index cancer diagnosis on this Kaplan-Meier curve. In addition, the authors employed 2 Cox proportional hazard models. In the first, the primary endpoint was time to cancer recurrence or second primary cancer, while in the second, the primary endpoint was time to exposure of biologic. Over a median of 6.2 person years of follow-up, there was no statistically significant difference in cancer rates in both models. This study has a number of strengths. It is the largest to date examining the safety of Vedolizumab in malignancy and includes a thoughtful statistical analysis to address potential confounders. It is also highly relevant to clinical practice. As the use of early immunosuppression gains traction and the number of patients with IBD continues to rise, management of IBD patients with a history of malignancy will grow ever more common. Many of the limitations of the study are inherent to the fact that it was conducted retrospectively. There is a risk of selection bias, with lower-risk patients more likely to be placed on anti-TNF therapy, and also of carryover effect due to use of different classes of medications. It was also insufficiently powered to examine risks specific to individual cancers. I will leave you with a few key take-home points. Use of Vedolizumab or anti-TNF did not increase the rates of new or recurrent malignancy in this study. In carefully selected patient populations, use of biologic therapy before the 5-year mark may be a reasonable approach. Conversely, in patients at higher risk for recurrence of cancer, longer than 5 years may be indicated as time to initiation of biologic was an independent predictor of recurrence. More prospective studies are needed to better guide our decision-making.